Well, good afternoon and good evening, everyone. My name's Hilly Page. I'm the Chief Innovation Officer for the Family Heart Foundation. On behalf of everyone at the Family Heart Foundation, I'd like to welcome you to our Heart Month webinar entitled From LDL Cholesterol to Lipoprotein a, Opportunities to Reduce the Rising Tide of Cardiovascular Events. And as you'll hear over the course of the next hour, unfortunately, the tide is truly rising for cardiovascular disease and cardiovascular events in our country. So we're going to do a deep dive this evening on LDL cholesterol and on Lp(a), two powerful risk factors for heart disease. And for the conversation this evening, I'm really thrilled to be joined by a true expert in the field. Dr. Keith C. Ferdinand is a professor of medicine, a preventive cardiologist at the Tulane University School of Medicine, and he's also a former board member for the Family Heart Foundation. And, as we jump in this evening, and again, I'd like to welcome everybody to our Heart Month webinar. I wanted to just give you a quick reminder on the Family Heart Foundation, just in case you're not that familiar with the organization. So on the next slide, I included a slide on the mission of the organization. We're a nonprofit patient advocacy organization that was founded in 2011. And the mission of the organization is to save generations of families from heart disease through timely identification and improve care of the two most common inherited lipid disorders. So that's familial hypercholesterolemia, or FH, which occurs about 1 in 250 individuals and has a diagnosis rate of around 30%. And elevated lipoprotein(a), which actually occurs in 20% of the population, or 1 in 5 individuals, but unfortunately has a diagnosis rate of only around 1%. And the organization focuses on research, advocacy, education, and empowerment to empower families to navigate their own health. And our website is familyheart.org in case you're interested in checking us out and learning more. I'd also welcome you on the next slide to follow us on social media, whatever your favorite social media channel is. You can sign up for our newsletter at familyheart.org, and we are very active with all sorts of informational updates on X, LinkedIn, Facebook, Instagram, TikTok. So whatever is your favorite social media channel, I invite you to follow us. Now, on the next slide, this evening's webinar is really informational only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not constitute medical or other professional advice. And we really encourage you, if you're a patient, it's so important to have these conversations with your own healthcare practitioners. But with that said, on the next slide, we really are hoping to answer a lot of your questions this evening. And so during the course of the webinar, if you do have a question, we encourage you to use the Q&A tab, not the chat, but the Q&A tab in Zoom to put your questions in. And I think we'll have time at the end to get to a number of the questions. We've got a couple of hundred people online tonight, so we're really excited to see the turnout for this webinar, but we'll get to as many questions as we can at the end. On the next slide, I wanted to let you know that this webinar this evening is part of an ongoing educational initiative called GOAL, G-O-A-L, or Getting on Appropriate Lipid Management. The Family Heart Foundation launched this initiative back in 2022, and the focus of the initiative is to improve awareness, treatment, and control of LDL cholesterol in high-risk Americans. And we really appreciate the unrestricted support from Amgen at a foundational level, as well as Merck, New Amsterdam Pharma, and Novartis for this initiative. It really made tonight's webinar possible. So we thank them again for their support. As part of the GOAL initiative, on the next slide, we had launched a new website on September 30th of last year called the LDL Safe Zone. So if you hear some things this evening that pique your interest, if you want to learn more about why LDL cholesterol is such a powerful risk factor for heart disease, we encourage you to go to the LDL Safe Zone. Lots of great tools, resources, video, educational materials, and you see the website there is ldlsafezone.org. And also on the next slide, I wanted to tell you about an exciting new program that we also just recently launched called Cholesterol Connect. This is a free at-home testing program for LDL cholesterol, lipoprotein(a), and also you have the opportunity to connect with one of our care navigators. So this doesn't go through insurance, it's totally free. If you go to cholesterolconnect.org, you order a test kit, it comes to your home. It's a simple finger stick test, and you mail that back. Within a week, we'll send you the results of your LDL cholesterol, your Lp(a), and you'll have the opportunity to connect with one of our care navigators. On the next slide, you see this is an example of what the test kit looks like, as well as the content. So on the lower left, that is the test kit itself. And it really is a very easy finger stick test. And we'll send you the full LDL, Lp(a), and on the lower right, you see a QR code. And if you want to take out your phone, if you scan that with your phone, that will actually take you to cholesterolconnect.org. Since we launched the program in September of last year, we've actually sent out over 7,000 test kits so far. So it's been an incredibly successful program. And if you haven't been tested for your Lp(a) ever, or if it's been a while for your LDL cholesterol, we would encourage you or your family members to order a test kit today. Now, before we turn things over to Dr. Ferdinand, I had a couple of polling questions just to get a sense of the audience and kind of where everyone is in their journey to the LDL safe zone. And the first question is, have you had your LDL cholesterol checked in the past 12 months? Yes, no, or not sure. So just choose whichever answer is the most appropriate in the next few seconds, and we'll see what the answers are. Find my glasses so I can see something. Wow, this is outstanding. So we do a lot of these webinars, and I can say in general, we always get about 40 to 50% of folks have had their LDL cholesterol checked in the last 12 months. So really outstanding to see what an engaged audience we have here. 94% have had their LDL checked. So wonderful. We're off to a great start. The second polling question is on the prevalence of familial hypercholesterolemia, or FH, in the US. So 1 in 500, 1 in 250, 1 in 1,000, or 1 in 50. A little bit of a spread here. So as I mentioned a couple of slides ago, the correct answer is actually 1 in 250 individuals have FH. So definitely not a rare disease, incredibly common, but unfortunately only about 30% of individuals with FH have been diagnosed. So correct answer, 1 in 250. And then our last polling question of the evening is around the prevalence of Lp(a). So what percent of the US population actually has a high level of lipoprotein a, 5%, 10%, 20%, or 40%. And if you go ahead and we'll launch the poll in a second here. I'm sure that folks got the correct answer, which is actually 20%. So 1 in 5 Americans has a high level of Lp(a), but the diagnosis rate, again, around 1%, because mainly it's not included as part of a standard lipid panel. And that's one of the reasons why we launched the Cholesterol Connect program, so that you could test yourself for free in the comfort of your home. And my final slide this evening is just to welcome my friend and mentor, Dr. Keith C. Ferdinand. He's a professor of medicine and the Gerald S. Berenson Endowed Chair in Preventive Cardiology at Tulane University School of Medicine in New Orleans, Louisiana. He's a former board member for the Family Heart Foundation. And the thing that is wonderful about Dr. Ferdinand is he's served on guideline writing committees. He's been involved in many cardiovascular trials in both the lipid and hypertension space. He's been an author on hundreds of papers. And probably the best thing of all is he still sees patients every week in his clinic. And so he still has a very active practice in New Orleans. And so with that, I'll turn it over to you, Dr. Ferdinand. Thanks again for joining us this evening.
Well, thank you, Hilly. It's always my pleasure to serve the Family Heart Foundation. You're so patient-centered. You deal with the science, but you also deal with the impact on individuals and their family. Next slide. So what I'm going to do for about 30 minutes, and we will have time for questions and answers. In fact, that's really important. Hilly and I would like to discuss some of these concepts with you when I complete the formal presentation, is to discuss the LDL cholesterol and lipoprotein a. Now, most of you know a lot about LDL. We need to know more about LPA because it's starting to become even more important as a diagnostic tool. We'll discuss the opportunities to reduce what we call the rising tide of cardiovascular disease. And we use that term because I'm going to show you some data that time does not equal progress, that we're actually not doing as well as we should in reducing deaths from heart attacks and strokes. Next slide. So I'll talk about the scope of the problem, why we are still talking about this. Well, it's Heart Month, so that's one really good reason. We will discuss LDL, LDL lowering and the goals. We'll talk about the report card, how we as clinicians, physicians, nurse practitioners, and others are doing in terms of lowering LDL. Then I'll go into lipoprotein A, which is the emerging cardiovascular risk factor. Here's the paradox being something that's the opposite of what you would think. Although atherosclerotic cardiovascular disease, and the acronym is ASCVD, is the leading cause of death and disability, it's highly treatable. So we can do better, but we're not doing better. Here are the data. The top bar in the red are real death rates from cardiovascular disease. You can see it outpaced some other really terrible forms of death, including cancer, COVID-19, unintentional injuries. If you take stroke and put it with heart disease, it's really high. So there's no doubt that if we're going to reduce death and disability to the United States, we have to address heart disease. I mentioned to you that time does not equal progress. The x-axis, which is above the line in the middle, if you go to the bottom, going from left to right, that is years. And you can see from 1980 to 2020, it came down for many of those years, but now, next slide, you can see it's going up. The other thing is, if a person has elevated LDL, the length of the exposure to that high LDL really plays a big part. So in this particular way of looking at the data, again, age is going from left to right, but the cumulative effect of the LDL cholesterol is going up on the y-axis. In the orange box, you see severe hypercholesterolemia. These are patients who have familial hypercholesterolemia. Now, in medicine, we have big names for everything. It really doesn't mean much. Familial means it runs in the family. It's predominantly genetic. You cannot diet your way out of it. Hyper meaning high. Cholesterol, a type of fat. Emia meaning in the blood. And you can see those persons will have very few cholesterol-free years, and I'll tell you about some of the data on that soon. You can see how that high cholesterol, even at a young age, impacts cardiovascular events. On the other hand, if you look at persons who have low LDL cholesterol, their genetics may be low LDL cholesterol, or they may have an excellent lifestyle, keeping that LDL down will prolong the life. Next slide. And you see that those persons with low LDL cholesterol, either by genetics or excellent lifestyle, or using appropriate medications, have a longer life. So this is not just theory. This is not just feelings. It's related to survival itself. Next slide. Let's go into a deeper dive in terms of FH, familial hypercholesterolemia. It's a genetic disease. It's caused by a mutation in which the liver cannot pull the LDL back into the liver out of the bloodstream. If you have circulating levels of LDL cholesterol which are high, they can then precipitate into the vessels. If it blocks up a vessel in the heart, that's the heart attack. If it blocks a vessel in the neck or the brain, that's the stroke. If it blocks a vessel in the legs, that's peripheral arterial disease. And as Healy mentioned, the prevalence is 1 out of 250 persons, but unfortunately, only about 30% of people actually are diagnosed appropriately. Here we see a family. It's a genetic disease, so it tends to run in families. If a person has FH, their LDL cholesterol is elevated starting at birth. Then if you look at those persons with FH and they're not treated, by the time they're age 40, which is quite young, 26%, or 1 out of 4 of them, will already have had a cardiac event, and 70% will have died from atherosclerotic cardiovascular disease. So LDL-C is still the primary target, and we'll look at now some of the evidence that tells us why we really should treat elevated LDL. Next slide. How do we know things? Well, Healy pointed out that the Family Heart Foundation is on the World Wide Web. We do use some of the social media, but you have to be careful. In science and in medicine, we make decisions based on real evidence. Our evidence that LDL cholesterol is a driver for heart disease and stroke comes from various sources, going from the top to the bottom, observable epidemiologic studies. Now, what that means is you take bunches of people. For instance, there's a town in Framingham, Massachusetts, where they just observe people for decades. People who have very high LDL have more heart attacks and strokes. Mendelian randomization and genetic analyses. We now can look at persons' genes, and certain genotypes will predict that they may have a risk of heart disease. Randomized clinical trials. This is perhaps the highest form of science. You take one group of persons and you put them on statins. You take another group of persons and you put them on placebo or a sugar pill. People who have high risk or who already have atherosclerotic cardiovascular disease and are placed on statins have less heart attacks, strokes, and death from heart disease. And of course, you can do animal experience. We're not animals, but it will give us an idea of what various medications and therapeutic interventions will do in animals, and then we can try to extrapolate that based on randomized clinical trials in humans. So let's look at some of the LDL-lowering interventions. Modern medicine is both pharmacologic, which is drugs, but it's also non-pharmacologic or lifestyle. Lifestyle is actually the bedrock and the first step for everyone. Heart-healthy eating can best be described by what you see here. First, focus on plant-based foods, fresh fruits, vegetables, whole grains, plant-based protein sources. Now, you don't necessarily have to be a vegan. Veganism, if done right, certainly can lower the LDL and protect against heart disease. What you really want to do is avoid highly processed foods. You want to avoid fats that are hard at room temperature. So that would be lard, butter, coconut oil, and include mono or polyunsaturated fats such as olive oil or canola oil, which are liquid at room temperature. You also want to lean sources of protein. That's beans, legumes, fish, especially cold water fish. That's the observation that tuna, haddock, salmon tend to protect against heart disease. If you're going to use chicken, the chicken breast, and some people really want to have that red meat, but it should be lean sources. And dairy, some people can't tolerate dairy, but if you can, low-fat milk or yogurt can give protein without a lot of saturated fat. So after this first step, the question is, well, what type of diet you should have? Well, the answer is in the red. A healthy diet is the one that you can take and maintain long term. In fact, we don't even like to use the term diet. It's an eating plan or a dietary plan. One called the Mediterranean. These are the persons who live along the the Mediterranean Sea, and they have low rates of heart disease. They use canola oil, olive oil. The DASH diet, originally for hypertension, but we now know those diets may help overall cardiovascular disease. Healthy vegetarian or vegan. We use the term healthy because if you're eating snack cookies, it may not be an animal source, but it certainly is processed foods high in sugar and it's not healthy. And volumetrics. This in general says that you're eating foods that give you a sense of satiety. It tends to have lower calories. Physical activity is part of it. You're not going to exercise your way out of having high cholesterol, but the American Heart Association says moderate exercise, 150 minutes, so that's 30 minutes most days of the week, will help with overall cardiovascular fitness and cardiovascular health. Now let's go into the pharmacologic approaches to lowering LDL cholesterol. Pharmacologic means drug, so it's how do these medicines work? The cartoon that's in the middle is the liver. The liver is actually the site where cholesterol is synthesized. So we now know if you can approach how the liver treats cholesterol, you can affect cholesterol in the body. The first step in terms of pharmacologic for patients who are high risk are statins. Statins because they end in the term statin. So that's going to be atorvastatin, rosuvastatin. And they work by what's called HMG-CoA reductase inhibitors. Big words. They block the synthesis of cholesterol in the liver. If you don't make as much cholesterol, then the cholesterol that's circulating in the bloodstream is sucked back into the liver by increasing what we call the LDL receptors. So statins are the first step in these very high-risk patients. One of the next drugs is called ezetimibe. And if you look at the package insert, it has a lot of side effects listed, but really most patients have no side effects with ezetimibe. It's non-systemic, meaning that when you take it, it doesn't go throughout the body. It blocks the absorption of the fats and cholesterol in the small intestines. It's not as powerful as statins, but it will add another 15 to 20% LDL reduction. A newer class of drugs includes bempedoic acid. It looks like it works just like a statin, but it's really upstream. The thing that makes it different from the statins is that bempedoic acid tends to work only in the liver, where statins can have a muscular effect. Some people get myalgia. It's a technical term meaning muscle aches. Whereas with bempedoic acid, because it only works in the liver and not in the muscles, you won't get that side effect. Next, we have the PCSK9 inhibitors. These are injectables. And what these drugs do is powerfully lower the LDL by blocking PCSK9. PCSK9 will degrade the LDL receptors that are sucking the blood from the bloodstream back into the liver. If you block or inhibit the PCSK9, it's called PCSK9 inhibitors, you can powerfully reduce the blood cholesterol. A cousin of the PCSK9 inhibitors is one called inclisiran. It's a little bit upstream because it turns off the signal that makes the PCSK9. So let's look at these various new drugs, and we have some cartoons of the pictures of what these drugs look like. First, let's look at ezetimibe. It's been FDA approved since 2002. Again, it's not systemic. It's a cholesterol absorption inhibitor. It's an oral drug, meaning it's a pill, and it can lower the LDL cholesterol 18 to 25%. It varies from one population to another. There are some studies now to indicate that adding ezetimibe will actually lower the risk of atherosclerotic cardiovascular disease. The next newer drug is bempedoic acid. Remember, it works similar to the statin, but it doesn't have the myalgia, the muscle aches. It's an oral pill, maybe not as potent as high-intensity statins, but it can be combined with ezetimibe and get 40% LDL reduction, which is pretty robust. There are some data now that bempedoic acid can improve atherosclerotic cardiovascular outcomes. The PCSK9 inhibitors are injectables, hence these pens. They've been approved for the last 10 years. They can be given every 2 weeks. At one time, they were given monthly, but now mainly every 2 weeks, and lowers the LDL a robust 50 to 60%. So if your LDL cholesterol is 150, you can lower it down to 75, and it does improve ASCVD outcomes. There are two, alirocumab and evolocumab. And on the bottom is a cousin of the PCSK9 inhibitors called inclisiran. It works by turning off the signal that makes the PCSK9 in the liver. It also has a robust LDL reduction of about 50%. Doesn't have the outcomes trials yet in clinical medicine, but works very similar. And we suspect that when we get those outcomes trials, we may have the same benefit that we've seen with the PCSK9 inhibitors. On the next slide, you see a robust list of all the various drugs and the LDL lowering that's expected. Expected is kind of a misleading term because some people will get a very, very high effect, some people will get less. So we have a range there. Can't predict that. At the top, we see diet. Now, that's fairly robust for diet. This person would really have to be on a fairly strict diet to get 10 to 15%. Some people, it's only 5% or 6%. High-intensity or medium-intensity statins can cut the LDL down 35 to 55%. Ezetimibe, 18 to 25%. I didn't discuss this one. It's a bile acid sequestrant, not as powerful, but can give some benefit. The PCSK9 inhibitors, alirocumab, evolocumab, potent LDL reduction, 50 to 60%. Inclisiran, a cousin of the PCSK9 inhibitors, about 50%. Bempedoic acid, similar to the statins, but does not have the same myalgia, not as potent, but can be added with ezetimibe and get close to 40%. What are the principles then when we as clinicians, whether we be physicians, nurse practitioners, clinical pharmacists, or others, what are some of the things we're looking for? One is we know that lower is better. We want to get that LDL down. Faster is better. We want to stabilize the plaque, leach some of the fat out of the plaque so it doesn't rupture. Longer is better. It's not good enough to have your lab values look pretty after a few weeks on a medication. It has to be maintained long term. These are the principles of both primary, that's before you have had a heart attack or stroke, and secondary, after an event, prevention. So regardless of how you approach it, if you have ASCVD, you need significant LDL reduction. For every 40 milligrams of LDL-C reduction, you lower your risk about 20%. Now, these cartoons are a little bit complicated, but I think I can simplify it. These are called Kaplan-Meier survival curves, and it's the way that we look at clinical trials. So on the left-hand side, you see the clinical trial with evolocumab. On the right-hand side, you see the clinical trial with alirocumab. They're in the maroon or red. They have a lower risk of having cardiovascular death, myocardial infarction, stroke, or revascularization, which is having bypass or angioplasty, when you use the PCSK9. These are non-statins. They can be added to statins, but they have a powerful and significant reduction in cardiovascular outcomes. Next, you see one of the questions that's often asked for my patients, well, yeah, these drugs really work, but suppose they work too well and the LDL comes down too far. Well, this is a study that looks at ultra-low LDLs, people who got their LDLs less than 10. And you still see that separation in the maroon, where lowering the LDL even less than 10 protects against major cardiovascular events. On the right-hand side in those bars, it shows the cardiovascular efficacy. Lower than 10 is in the red or maroon. The primary outcome in cardiovascular death, myocardial infarction, and stroke are lower with more robust LDL reduction. Next to that is safety. Well, it doesn't appear to be non-safe. It's not really bad. Serious adverse events, about the same. Even drug discontinuation, about the same. This is another Kaplan-Meier survival curve, and you can see how it separates. It looks up to 5 years with PCSK9 inhibitors. Remember, they've been around about 10 years. So this is an extension of a clinical trial. And you can see that the separation versus usual care remains. Lower is better, longer is better. So what are our LDL goals? You also hear the term threshold at which you should be lower when you're trying to get the LDL down. Let's look at those data. What's suggested is you look at who the patient is. On the left are certain high-risk conditions. And you know, these high-risk conditions are quite common. I still have clinical practice, as Hilly said. Any person who's older, especially patients with familial hypercholesterolemia, if they've had prior coronary artery bypass or an angioplasty, patients with diabetes, hypertension, which is over half of the population, kidney disease or chronic kidney disease, CKD, smokers, LDLs that are still greater than 100 despite maximally tolerated statins or a history of congestive heart failure, these patients are high risk. Next to that, you see patients who've had a major atherosclerotic cardiovascular events. They've had a recent ACS, a myocardial infarction, a history of stroke, or peripheral arterial disease. Once you have these high-risk conditions and you combine them with major atherosclerotic cardiovascular events, then caution. You're considered very high risk. And having multiple of these events, or one major ASCVD event and multiple high-risk conditions, which I've already suggested are very common, these patients are at very high risk, regardless of how they feel. Now, the guidelines in the United States are lagging a little bit. We may be working on some new guidelines in the future, But if you look at the guideline from 2018, it suggests these patients who are very high risk will need, along with statins plus or minus ezetimibe, the use of PCSK9 inhibitors to get the LDL less than 70. On the next slide, it goes even further. This is not a full guideline. It's called a consensus pathway or working group. And they suggest in these very high-risk patients, less than 70 is good, but not good enough. And they lower the threshold at which you really should try to drive the LDL less than 55. And this is not uncommon. There are almost 66 million adults in the United States who are very high risk and need these LDLs at these very low levels. Well, let's look at our report card. When we have our children come home from school, they bring a report card on how they're doing. Unfortunately, next slide, what the report card says is that we're not doing as well as we should. And the Family Heart has one of the largest databases that demonstrates that, over 324 million US individuals. We look at patients who have both severe hypercholesterolemia, elevated ASCVD risk, or clinical ASCVD risk, and then we compare them to getting to these thresholds. You want to get the LDL down less than 100, but in those patients who have documented ASCVD at the bottom, you want the LDL down less than 70. So this powerful database tells us as clinicians how we're doing in reaching these goals. Let's look at the data. In the Family Heart Foundation data, what it shows is that LDL thresholds, getting less than an LDL of 70 in these high-risk patients, is found in a very small percentage. And 70% of the patients are above where they need to be. We're not doing well in terms of treating these patients who are high risk. Therefore, if you look in the red, we see the poor person is in a hospital bed. Having that LDL above that threshold, not getting them down where they need to be, will increase the first cardiac or heart event 44.2%. And if they maintain that threshold, above that threshold, subsequently, 49% or higher are going to have an event. So getting that LDL down is important. It's not a numbers game. It's not just looking at a lab slip. It protects against cardiovascular events and cardiovascular death. So in summary, how have we been doing? Well, going from left to right, most high-risk patients remain above their LDL threshold. We're not getting them down to less than 70, and certainly we're not getting those very high-risk patients less than 55. Next, if you look at those patients who are below LDL thresholds, many of them are only there for brief periods of time. They don't maintain it. And in the United States, there's an insufficient prescribing of what we call combination therapy. I talked about the different medications, but we often have to combine, for instance, a statin with the PCSK9 inhibitor in order to really lower these LDLs. And then finally, these high-risk patients who are persistently at a high LDL level have an increased risk of major cardiovascular events. So it's not a numbers game. It's really death and disability that we're trying to combat. Now, some of you may not want to take medicines, and we've already said we're not treating patients, we're just reviewing some of the data. But what I tell my patients is that if you take anything into your body, the question is not whether or not you got it from a drugstore or a health food store, but whether or not it has a benefit. This is a very interesting study because it looked at a group of high-risk patients and asked the question, well, suppose you don't want to take a medicine. It looked at low-dose rosuvastatin, a very low dose, 5 milligrams. Most patients take 10, 20, or even 40 milligrams. And it compared that 5 milligrams rosuvastatin to a placebo, which is a sugar pill, no medication, and then compared it to dietary supplements, those things which we hear on the radio or see on the internet that are supposed to be so great for the heart. Let's look at what the study showed. It showed in 190 participants, the percent of LDL reduction with rosuvastatin was greater than the supplements. The p-value, anything less than 0.05 is considered significant. The p-value was less than 0.001. Compared then to placebo, it was 35% lower, and none of the dietary supplements demonstrated a significant decrease in LDL cholesterol compared to placebo. The adverse events were about the same across all of the study groups. Let's look at the data. Here you can see who the patients were. They were 40 to 75 years of age, so these were older persons. Their LDLs were above 70 or less than 189, and their 10-year risk of having a major cardiovascular event was 5 to 20%. What agents did we look at? Well, rosuvastatin 5 versus placebo, but also compared to fish oil, cinnamon, garlic, turmeric, plant stanols, and red yeast rice. What did the study show? Arrow down with rosuvastatin, LDL came down, total cholesterol came down, triglycerides came down, no change in the HDL or the HSCRP, but no change with any of the supplements compared to placebo. So this doesn't mean that you don't use supplements, but if you need that LDL reduction, you should test. And in this particular trial of 190 patients who are high risk, even a low dose of rosuvastatin was superior to placebo, fish oil, cinnamon, garlic, turmeric, plant sterols, or red yeast rice. So final thoughts on LDL cholesterol. Then we're going to look at lipoprotein little a. The final thoughts are the following. Get tested and follow up. Make sure that what you're doing, whether it be a drug, lifestyle, or if you want to use some type of supplement, make sure that really getting that therapeutic effect. High-intensity statins are often needed to get the LDL down 50% or greater, and some patients may get there with moderate-intensity statins. Adherence, meaning staying the course, is what's really important to lower LDL. If you don't do that, you're flying blind, meaning that you're working in an environment where you don't know whether or not you're getting any benefit from what you're doing. All right, so let's switch gears. And here are the conclusions. We'll keep going. We're going to move over now to lipoprotein little a. It's an LDL-like substance. It's a little different. And what it does is it has the LDL, that yellow ball, but it has an ApoA. It's a protein that's attached to it. It then can precipitate in the brain, increases strokes, precipitate in the heart, increases heart attacks. It can damage the aortic valve and cause aortic stenosis, and it can go to the extremities and cause peripheral arterial disease. What is a high LPA? Well, you have to really look at your lab slip carefully. If it's in milligrams per deciliter, elevated is greater than 50. If it's in nanomoles per liter, it's 125. We don't really know why people have elevated LPA, but we do know it varies across regions of ancestry. It's very common worldwide, 1.4 billion persons, and it tends to be somewhat more common in people of sub-Saharan Africa and South Asian ancestry. And this may be one of the risks that you see in these populations who do tend to have more cardiovascular disease. This is a large trial in the United Kingdom called the Biobank, in which they draw blood and they look at patients' self-identified ancestry. You see the blue. The persons who identify as Black tend to have higher LP little a's. And in sex, it's about the same for men and women, but maybe even a little higher in the women. If you have LP little a, you should recognize that this is a genetic condition, and you do what's called cascade screening. You do the same for familial hypercholesterolemia. If you have that LDL that's above 190, which is a surrogate for FH, you should have your family test. The same is true if you have an elevated lipoprotein A. How often should you check? Well, if you look at the guidelines and scientific statements, they're all over the map. Some of the more recent statements, however, the EAS, is the European Atherosclerotic Society, suggests check it for everyone. And the Canadians say at least once in a lifetime, get an LPA check. So does the National Lipid Association. Extremely high LP little a's has a risk similar to persons who have familial hypercholesterolemia. In fact, patients with FH or familial hypercholesterolemia tend to even have more elevations in their LPA. Why measure it? Because it is a risk factor. It's not just a risk enhancer looking at the data. Prevalence is the most common of the inherited dyslipidemia, dys meaning bad lipids. It's a genetic factor, and it complements our knowledge of the other lipid profile. It may lead to early interventions. We don't have FDA-approved therapies for LPA, but it can lead us to intensify the conventional risk factors and do cascade screening, check other members of our family. It increases our therapeutic options, it enhances our awareness, and it's cost-effective in the long run to check this because it brings attention to the need to have more intensive risk reduction. Unfortunately, in some of the older studies, only less than 1% of people have had their LPA tested. And this is why the Family Heart Foundation is offering free checks of LPA. There is a code. Clinicians who are in the audience can look at this code, and if you ask your clinician for an LPA test, you can tell the clinician that there are codes that are available. PCSK9 inhibitors are not approved to treat LPA. Their treatment is for LDL cholesterol, but it has been shown that they can lower LPA at least 15 to 30% in two of the outcome studies that we looked at previously. But again, this is not an FDA approval. And in those patients who have atherosclerotic cardiovascular disease and severe elevations of LPA, they may even need a type of machine approach called apheresis. It's very similar to dialysis, where you suck the blood out and cleanse it of the LPA. We do not have FDA-approved therapies, but there are some on the horizon, and hopefully the studies will show that these various approaches to turn off the signals that make LPA in the liver may cause a decrease in cardiovascular events. We don't know that yet. Those studies are ongoing. Well, thank you. I covered a lot, but hopefully we'll have time to chat and answer some questions.
Dr. Ferdinand, thank you so much. That was really a superb presentation, very comprehensive. As you say, you covered a lot of ground, and we have a lot of questions. We have over 200 people on the webinar, and as you can imagine, we have a lot of questions. So I'm glad we've got some time left here at the end to address a lot of really great questions. The first one we get all the time, so we've done a number of these webinars, and we always get a request for the slides, and so we will definitely make the slides available. I think when folks register for the Zoom, we capture your contact information. So typically we'll send a thank you note as well as a PDF of the slides, and so we'll get those out. So thank you for that request. We have one question around dietary approach to FH, and the question is around a high-fat, low-carb diet for FH, and whether that would be helpful.
No, it really is not recommended. Diets are hard to change FH. Remember, it's a genetic condition. There are some data that low carbohydrate diets, not high fat, lean sources of protein, less refined carbohydrates, it's beneficial. It lowers the LDL somewhat, and it will protect you somewhat. But persons who really have FH are going to need medications. In the Danish population, that's Denmark, they start statins at the age of 6. It sounds terrible, but they now have outcome studies, they've been doing this for over 10 years, that if you start treating these kids early, you decrease the chances of them dying early.
That's excellent. Question on stability of Lp(a) over time. Somebody had it tested a while ago. It was normal, but wondering whether or not it changes and evolves over time, or is it fairly consistent?
Well, we used to say check it once because it was a genetic factor and you know what it is for the rest of your life. Unfortunately, life is not that simple. We know in women, for instance, after menopause, after about 4 or 5 years, the LPA goes up. It may be one of the reasons older women tend to get more cardiovascular disease. Certain conditions, if you have hypothyroidism, the LPL goes up. If you have kidney disease, it's excreted by the kidneys. So a person who develops kidney disease, the LPL will go up. Certain inflammatory conditions. And then really to make it more complex, Hilly, as we start to do more testing, there is some variation even without those secondary conditions. I still say get it checked at least once. If it's very, very high, it's not going to change. If it's very, very low, it's not going to change. If you're on the border, then maybe you'd want to check it again in 6 months or so after you've done some initiation of therapy to see what it's done.
Okay. It's probably worth letting folks know just there are two different assays. And so sometimes we get confusion for folks who get it measured in milligrams per deciliter and then again in nanomoles per liter. And so maybe a word or two on that would be helpful.
The nanomoles per liter on your lab slip is going to be NN/capital L. The milligrams is going to be mg. And the milligrams is about 2.5 times less than the nanomoles. So you can get it checked and it might be 50 on the milligrams. Then you check it on the nanomoles and it could be 125. And you say, wait a minute, it's gone up over 2 times more. Well, it didn't. It was a different assay. So always look not just at the number, but what's written after the number.
Sounds good. And in Cholesterol Connect, we test in nanomoles per liter, which I understand is the preferred assay.
Yeah, we're now trying to push it that way because it can be validated and it can be checked universally. The Europeans use mostly nanomoles, but we will still see some people out there with milligrams per deciliter.
Question on guidelines that we've, I guess, kind of lagged behind in the US, some of our European and Canadian counterparts, but are there any organizations in the US that are recommending Lp(a) testing?
Yes. So the National Lipid Association is a specialty organization, lipids meaning fats. I was on the board for that for many years. And they just updated their recommendations to suggest getting it checked at least once in a lifetime.
Okay. There's a great question we get all the time, and it is around ApoB. So somebody has effectively treated their LDL, but their ApoB hasn't budged much, and they see a lipidologist who says the only thing that matters is ApoB. Forget about LDL. And so maybe you could address what is ApoB and any thoughts on its relative importance.
Sure, the lipid experts will tell you ApoB may even be more predictive than LDL cholesterol because ApoB is the number of proteins that's carrying the LDL cholesterol. So the number of proteins carrying the LDL cholesterol will be more predictive than just the amount of cholesterol in the blood. That being said, in your conventional lipid profile, they're measuring a calculated LDL cholesterol. And in almost all of your major cardiovascular outcomes trials, they measure LDL cholesterol or they calculate LDL cholesterol from a formula. In usual clinical practice, I have clinic in New Orleans at least twice a week. I see high-risk patients. I tend to stick with just treating the LDL. It's a little simpler, it's a little straightforward, but a lipidologist, a lipid specialist may suggest to you that you look at ApoB because it's a better marker of the number of LDL particles in the body.
That's great. Very clear. Another question we get all the time is link between statins and dementia. And is there a link? And if so, is one statin better than the other?
I'm smiling because not only do you get it, I get it, and I'll probably get it this week in clinic. The idea that statins cause dementia is just not true. When they looked at the observational trials, we now think that yes, the brain has cholesterol in it, and it does make what appears to be common sense that if you lower the cholesterol, you don't have enough in your brain, but the brain makes its own cholesterol, and you certainly have enough. Here's the way I explain it, Hilly. If you look at non-westernized, non-industrialized societies, rural Africa, rural China, Amazonian Indians, they walk around with LDLs of 30 and 40. I mean, that's average, and they do well. So lowering the LDL from the average in the United States is 113 to 115. Our average is too high. And this idea that we are going to cause harm, I really don't think that makes sense. We were born with LDLs that low, and people in those non-westernized, non-industrialized societies walk around with LDLs. They die from trauma and infections, but they don't die from heart attacks and strokes like we do here in the Western world.
Well, that's reassuring. My rosuvastatin keeps my LDL at a consistent 40, so I'm glad to hear.
You're okay, and your mentation appears to be intact.
There we go. At least so far. Another question, again, very common around HDL cholesterol. Do you need to worry about it? Used to be
Wow.
very
Well,
fashionable.
you have a smart audience there. We used to call HDL the good cholesterol, and many of you, if you go to your clinician, whether it be a physician, nurse practitioner, clinical pharmacist, they're going to tell you your HDL is high, and that's really great. I don't do that. We now know that HDL may have a beneficial effect, but when the HDL is really high, let's say it's a 90 or 100, the dump truck is full. The HDL does what's called reverse cholesterol transport, where it picks up lipids and brings it back. Well, if the HDL is really high, you can't do much more in terms of reverse cholesterol transport. We've even tried giving patients an infusion of HDL, and it really has not shown benefit. In the non-Hispanic Black population or African American population who have high risk for cardiovascular disease, the HDLs tend to be a little bit higher, and it certainly is not protective in that particular population. I do not put a lot of emphasis on this good cholesterol, LDL cholesterol being bad. I look at the LDL cholesterol, I look at lipoprotein little a. If the person is really high risk, you can make the case for ApoB. I put much less emphasis on HDL.
Awesome. Very clear. Um, for statin muscle pain, anything that is you would recommend, magnesium, CoQ10, anything that you've seen that's successful?
Well, we really don't know. It's about 10% of persons. There have been some studies in which they switch patients back and forth from a statin to a placebo, back to a statin to placebo, and the patients really can't tell the difference. The muscle pain tends to be generalized in large muscles. If it's just a pain in the knee or a pain in the elbow, then it's not the statin. It could be as high as 10% or greater. There's some data that the water-soluble statins, rosuvastatin, pravastatin, pitavastatin, may cause less of it. There's some data that if you use high doses of coenzyme Q10, it may be beneficial, but I don't recommend coenzyme Q10 on a regular basis. And there are some data that perhaps vitamin D may have some effect. I recommend vitamin D, meaning more protective for its effect against infections. You know, it affects the immune system, might affect muscle aches with statins. What we tend to do, however, is change the script, go from one statin to another. Remember, there's bempedoic acid, which doesn't work in the muscles, it only works in the liver. And if you're very, very high risk, don't forget about those injectables. They're not bad. PCSK9, inclisiran doesn't have the outcome study yet, but we expect it will be effective, can lower LDLs 50 to 60%.
Yes, in fact, to back up what you're saying, one of the other comments is somebody who kind of struggled with a statin and has found great success with a PCSK9 inhibitor and is just wondering, why people are forced to go through statins first and, why not a PCSK9 monotherapy?
We're going to do a webinar, Hilly, on the business of medicine. And the business of medicine often makes us get what's called prior authorization. We have to fill out a bunch of forms, and then we have to do a peer-to-peer where we call some retired physician in Iowa, I'm in New Orleans, and talk to him about why we need to treat our patients. It can be really a burden on clinicians to have to go through that process. It's probably because the PCSK9 inhibitors are quite expensive, so they don't want to break the bank with the healthcare industry. But if you need to lower the LDL cholesterol, these injectables, both the PCSK9 inhibitors, alirocumab, evolocumab, and the one that's the MSIRA silences the protein made in the liver, the inclisiran. Those drugs work really well, and they're really well tolerated.
And sadly, probably the retired physician in Iowa is a pediatrician that you're busy trying to convince of the importance of treating lipids.
No, it's usually an ophthalmologist.
Oh, there we go. A true specialist. Yeah, and I'm of course out in California, and one thing that people don't really appreciate is the role of the state insurance commissioner. So our Department of Managed Healthcare published data recently that very few people will challenge denial, but of those that challenge the denial, 75% are overturned successfully if you appeal to the Department of Insurance. And so it is worth working with your clinician to fight these things if you feel like it's important for you to get the therapy.
I would say that the Europeans are much more robust in their goals, and they suggest all of these high-risk patients get less than 55. And they say in patients who've had recurrent events, have had 2 heart attacks, a heart attack and angioplasty, a heart attack and bypass, less than 40. So the
Yeah.
Europeans really believe lower is better. I believe it too, but they have written it up in their guideline.
This is an interesting question. It's kind of an intersection of the two topics we've had this evening. So somebody with a family history on imaging, they have stenosis, and so they have atherosclerotic cardiovascular disease. They've done a good job controlling their LDL and getting it from about 180 down to the 60s, but they got tested for their Lp(a) and it's over 300 nanomoles per liter. And sort of wondering what else they can do, what else if in the face of managing the LDL, is there anything else that you can do to lower risk?
Right. Remember, we're not treating individuals, but in general, in those particular patients, I would drive the LDL down even further, and I would consider a PCSK9 inhibitor not approved for lowering LPA, but it will give an additional 20, even 25% LPA reduction. And if they've had a vascular event, angioplasty, stent, high-grade stenosis or blockages, I may even consider low-dose aspirin. Those patients are at high risk. And risk doesn't mean symptoms. You can feel pretty good and be high risk.
That's great. And I think the other thing I would mention is, as you mentioned at the end, Dr. Ferdinand, there are a number of therapies in development. And so if folks will check our clinical trial page on our website, there are a number of companies that are enrolling for their therapies for Lp(a). And so that can be an option too for folks that meet the entry criteria. Another question on interesting combination therapy. So this idea of pushing the statin to the maximum dose or mega doses of statins versus lower doses of, maybe a statin and Zetia or a statin and PCSK9. Any thoughts on kind of that approach?
Yeah, I have a lot of thoughts on that. A lot of my work is in hypertension. That's where I've done a lot of publishing. And in hypertension, we believe that combination therapy, even low or moderate doses of two agents, is better than pushing one drug to the max. We now think that may be true with lipids. In fact, if you take the statin and you add ezetimibe, that extra 15 to 20 to 25% may get you to the goal you need. Or you take the statin and you add the PCSK9 inhibitors, will clearly get most patients down to where they need. So yes, combination therapy, just like in hypertension, is the way to go in lipids. I would rather see the patient use combination therapy than just push the statin to the highest dose alone. Oh, one other thing, Hilly, when you push, there's something called the rule of sevens. So if you had a atorvastatin 40 and you double it to 80, you don't get double LDL reduction. You only get about 7% lower. If you're on rosuvastatin 20, you go to rosuvastatin 40, you don't double the lowering of the LDL. You only get about 7% more. The rule of sevens. So you do better adding ezetimibe than doubling the dose to the highest dose.
Perfect. Maybe one last question here before we wrap up, and we've got about 30 unanswered questions. And so I may go through, if there are any themes, I may get your help, Dr. Ferdinand, in addressing some of these, and we can do, we may have a need for a follow-up webinar here. There's so many questions and a lot of great ones, but a question on, when are the Lp(a) lowering drugs coming out?
Not soon, unfortunately. One of the first studies is with a drug called pelacarsen, and the call out for it will not be this year. So treat the conventional things that we know. Add the PCSK9 inhibitors if you need additional LDL reduction with Lp(a). Consider the other risk factors: glucose, blood pressure, weight, exercise, smoking. The drugs that you showed, the investigational drugs, are not going to be available. Clinical trials are there, and you can seek through the Family Health Foundation where clinical trials may be next to your geographic location. But in terms of an FDA-approved Lp(a) lowering drug, nothing this year.
Yeah, we have a very robust clinical trial site on our website, and we're able to connect a lot of folks with not only the Lp(a) therapies, but there are also a number of exciting LDL lowering therapies in development as well. Maybe one last one is just for a fasting lipid profile, how long should somebody fast? What's the recommendation?
We say 12-hour fast, but I'm going to tell you, when I have clinic, if that person's eating and they're there, I tell them go down to the lab and get your blood drawn. It will affect triglycerides, has very little effect on LDL or total cholesterol, and extremely very little effect on Lp(a). I'd rather them go get the blood drawn than, especially now with the cost of transportation, I'd rather them go down to the lab and get it drawn than come back next week or weeks later. In fact, some patients don't repeat that blood test that I may have wanted.
Awesome. That's excellent. Well, if we can bring the slides back up for a moment, Susan, I'll just wrap things up this evening. Again, we really appreciate so many people joining us, and we got to a lot of questions. We didn't get to a number of additional ones, but we really appreciate all of the interest and engagement. And if you have additional questions, if you have FH or high Lp(a), we have a care navigation center that's staffed by three excellent individuals who can help you navigate your healthcare. If you're looking for a clinical trial, if you've been denied a therapy and looking for support on the prior authorization process, really expert individuals in our Care Navigation Center. So I encourage you to reach out. On the next slide, March 24th is the fourth annual LPA Awareness Day, and we really encourage you. This is something that was founded by the Family Heart Foundation. We encourage you to join us on March the 24th. If you want to learn how to get involved, go to lpaawarenessday.org. And then the final slide, of course, we're a nonprofit patient advocacy foundation, and we really always appreciate any support and donations. And thank you in advance if you are able to offer anything in the way of a donation. And finally, just again, a big thank you to Dr. Ferdinand for really a superb presentation covering LDL cholesterol, Lp(a). We thank everybody who joined us. This is one of our most popular webinars I think that we've had in the last couple of years. Over 200 folks online, lots of great questions. We'll make the slides available. We'll get those out to everybody along with a thank you note and maybe some infographics as well. But thank you again for joining us. Thank you, Dr. Ferdinand, and hope everybody has a wonderful evening.